locally advanced breast cancer, and metastatic breast cancer. For today's session, I feel honored to welcome our esteemed chairperson, Dr. Srinivasa Naidu, sir. Sir is assistant professor and consultant medical oncologist at SRMS Bareilly. Sir has completed MD radiation oncology, after which he has completed DrNB medical oncology and is European certified medical oncologist. He has special interest in hematological cancers, medical oncology and genetics, oncofertility, head and neck cancers, and gynecological malignancies. He has been awarded Commendation NB Government of India for research paper on addition of enzalutamide to chemotherapy in endometrial cancers. Sir has received AROI Neil Joseph Fellowship in Trivandrum in 2018. Welcome, sir.
Thank you. Thank you. Today, I would like to welcome Dr. Anushree Chaturvedi. Can I have that slide?
Yes, sir. I've shared it. Is it visible, sir?
Right. Not on my screen.
So actually, there are two screens. You can check the first screen. Which
Right. I got it. Right.
Yeah. Okay, sir. Yeah.
I would like to invite our speaker of the day, Dr. Anushree Chaturvedi. Madam is an assistant professor, National Institute of Medical Sciences, Jaipur. Madam has a number of international journal publications and also research projects as a primary investigator. She has given talks and presentation in American Society of Hematology, which was held in San Diego. Make you aware for all the students and all upon the breast cancer management fund. Thank you.
Thank you, Dr. Srinivas. Am I audible?
Yes, ma'am.
So let's begin. So it is a vast topic, but I think we'll start with the basics and then add on to the approach. As we know that this will be our plan of study for today. We'll be studying that we know that most common, about 70% of breast cancers belong to the hormonal positive group. In total, how we divide. That is with luminal A, luminal B, HER2 and triple negative. That is the basic division. As per the criteria, any tumor cell that is more than 1% positive is considered hormonal positive. Among this, there is luminal A and luminal B like and with HER2 negative versus HER2 positive. Luminal A are better prognostic. They have low E67 and HER2 negative and very high ER and PR positivity. Luminal B will be high ER positive, PR may be positive, may be negative, and with a higher E67 index and with HER2 positivity. So there, first, we'll be going with the practice approach also and with the controversy approach in each and every aspect of the treatment. So what is practice? It is any tumor IHC that is more than 1% is considered as hormone positive. Now the question arises, that is hormonal low. We know that HER2 low is it is now and drugs are available also. And what is ER low? ER low are considered that are 1% to 10%. So like a controversy exists, do we have to give an hormonal therapy even if it is less than 10%? What is the prognosis? What is the role of hormonal in treatment? As per the guideline, it is considered hormonal low, but most of us, or practically because of the prognostically, it is treated as TNBC, more likely. But I think a recent paper had addressed the question, and it has showed that if we avoid adjuvant hormonal therapy in patients with ER 1 to 10%, it leads to worse prognosis. So at the outset, ER 1 to 10% are low, but yes, we have to give adjuvant endocrinal therapy in such patients also. Now, second topic that we should address, and we should know the basis is genomic assay. That is the genomic expression profile in hormonal patients. That is, it is most important and to help us decide the adjuvant line of treatment in hormonal positive patient. There are various assay for that. What we are more that is useful or more certified is the Oncotype DX. The other are Mama Print, Prosigna, Endopredict, and Breast Cancer Index. And our Indian grown is Can Assist. What are these? These are like gene expression assays. What we do clinically is one that we see the patient clinically and we do a clinical pathological correlation to assess the risk prognostication in hormonal early breast cancers. What a genomic assay does, that it divides the patient in risk group on basis of genomic assay on the basis of genomic assay. They divide in the patient in low risk, intermediate, and high risk group depending on the assay. The one that is standardized and approved and both prognostic and predictive is the Oncotype DX. Why? Because both the retrospective and prospective studies have established its role. Another one is MammaPrint. Though breast cancer index, endopredict or Prosigna PAM50 are there, but they are more of a prognostic markers than a predictive marker. So we'll focus our attention on the Oncotype DX. So it is a 21 gene recurrence. We take a tissue, it is centralized. That is why it is a centralized test. So the cost is exuberant. So that's why most of the patient are not able to afford it. But right clinical decision making, if the patient affords it, then genomic assay Oncotype DX is the preferred. It divides the patient into low risk, intermediate, and high risk. The cutoff is 11 to 25, and more than 25. So, what were the trials? These are two trials on basis that has proved its efficacy. That is the TAILOR-X and the Responder trial. It is used both in the pre and post-menopausal women and with node N1 positive. And it is as per the level 1 evidence is supportive of Oncotype DX. Next, we'll see that what is the study that established. So it is then the TAILOR-X study. It was mainly in the node negative category of the patient. In that, the recurrence score is 10. Then the use of chemotherapy did not had positive influence, and chemotherapy can be avoided in such patient. If the recurrence score was more than 26, it is high risk category, and chemotherapy with adjuvant endocrinotherapy is prescribed in the patients. So what was the middle, that is 11 to 25, that was a query group. So because it's not definitive. Another trial, it showed that in the premenopausal versus postmenopausal. Usually in the premenopausal, as we know, less than 40 years and premenopausal also, they are poor prognostic or in high risk category. In that, they show that there was role of chemotherapy was better in such kind of patients. And another than the node positive patient, it was the responder trial. It again divided the patients into two groups, in the less than 25 and more than 25, and basis of pre and postmenopausal. So basically, it showed that there was no chemotherapy benefit in patients that were postmenopausal and 1 to 3 lymph node positive. So it was established. But in the premenopausal, there were two ranges, 0 to 13 and 13 to 25, 14 to 25. In both of these patients, it could be that because of they were given chemo, that lead to ovarian suppression, or they were patient were advised chemo because they were already in high risk. So if ovarian suppression is not the explanation, then invoke some predictive factor for chemotherapy that is not accounted by age or Oncotype DX. So ovarian suppression may be an adequate alternative to chemotherapy for many premenopausal women with a risk score of less than 25 and node positive. So again, highlighting the importance of the study, that there was a interaction between the disease-free survival versus the treatment. So this is a table that we can have for the clinical decision making in patients with hormonal positive and early breast cancer. In good risk patient, Usually it is like the better histological type and good prognostic. Usually any the GES or expression is not required. In postmenopausal patient, chemotherapy can be avoided on basis of oncotype DX, which has a category 1 recommendation, and node positive patient basis of less than 25 or more than 25 risk scores. But in premenopausal node positive, still there is no optimal no optimal choice, and it could be based on your clinical pathological factors. And patient, another important role of these score can come in deciding the patient for adjuvant endocrine therapy and deciding the optimal timing and duration for endocrine therapy. So in that the BCI index and Prosigna endopredict plays role. Now, this is what the two basic that we need to understand. Now, let's go on to the hormonal therapy. First, we'll go with the basic. So, how does the estradiol actually act? Estradiol is it's a nuclear. It acts by production. First, the production in a premenopausal is the primary site will be ovary, and in the postmenopausal, the primary site will be the fatty tissue muscles. So in primary patient like premenopausal ovary is the site estradiol production happen. Estradiol production lead to the formation of estradiol, and in the cytoplasm, the estrogen receptor is there. The estrogen receptor then lead to dimerization, and then combination with the estrogen receptor element. So here, the dimerization and receptor element leading to a general transcription happens. So these, as estrogen positive cells are both heterogeneous, few majority positive, but few are negative also. So estradiol has an effect on both the cells. Another is the peripheral, how the conversion in the postmenopausal happen. In postmenopausal patients, the testosterone get converted to the estradiol, and testosterone is converted to estrogen and then to estrone. And the conversion happens by the aromatase inhibitor. So when we are acting on the hormonal therapy, we are by the tamoxifen, we are blocking the selective modulator, and by AIs like anastrozole or letrozole, we are blocking the conversion. Again, this happens at the genetic level. We need to know and understand this because it will help us understand the what is the receptor mechanism, the resistant mechanism in hormonal positive patient. So basically, when the estrogen combines with the estrogen receptor, a heat shock protein reactions happen, and there is a release of the estrogen response element that acts on the DNA. When this acts on the DNA, it leads to phosphorylation and phosphorylation of the coactive enzymes. So there is a coactive enzyme and there is a transcription happens. When this transcription happens, then the proliferation of the cells take place. And by the type 1 and type 2. This type 1 versus type 2 helps in decide like if tamoxifen is acting. Tamoxifen is positive as per the receptor, like for the breast tissue, it is positive. It is positive for the endometrium tissue. And it is, an antagonism for the different. So the differential expression by the type 1 and type 2 gene helps the tamoxifen to be acting on two different receptors and having a both an agonist on some tissues and antagonism on some tissue. So we can see if the tamoxifen binds in place of estrogen, the tamoxifen binds with the receptors. It is a co-activator for some type 1 gene, leading to agonist effect like on the uterine endometrium. And when it is activating the co-receptor, it is leading to antagonism on the type 2 genes like the breast and the breast tissue. Now, second. So this is the hormonal therapy on the DNA level that we must understand to know the effect, the positive, the negative, and the resistance further. Now, one thing I also in this mechanism, one we need to know is the crosstalk. Why the crosstalk? Because of the two reasons. Because in clinical practice, there is we come across patients with that are both ER positive and HER2 positive. So the mechanism is just not the estrogen is acting on the estrogen receptor and then the nucleus, but also they have a crosstalk between the HER2, the EGFR receptors. So they have a common downstream signaling pathway. So even without the estrogen receptor, the estrogen ligand, the receptor can activate the downstream signaling pathway. And same can happen with even if there is overactivation of the HER2. So it is both the crosstalk between the HER2 and the estrogen lead to a mechanism that is free of ligand binding. So without the estrogen ligand also, they can continue the cell proliferation and activation that by the PIK3 mechanism and RAS, RAF and MEPK mechanism. So anytime we are talking about the treatment in HER2 also in HER2 low cases that are hormone positive, the triple positive cases, we say that they need a dual therapy, that is the anti-HER2 plus the estrogen-based therapy. Now let's start with the endocrine therapy. Endocrine therapy in breast cancer, the first and the foremost was the tamoxifen that was introduced. Tamoxifen, when introduced, it helped. Initially, it was planned for metastatic breast cancer. It showed very good result. The dosage that we know is 20 mg, but initially a very high dose was used, which led to side effects. But later we came upon a 20 mg dose, and which was a very favorable and with very tolerable dose. So initially used in metastatic breast cancer. Then with the NSABP studies, the role in prophylactic also and adjuvant came. So what is the role in endocrine therapy in adjuvant cancer? If we are adjuvant treatment we are using, we are leading to a risk reduction in recurrence by 41% and a breast cancer mortality in 34%. And it is favoring the any subgroup by age less than 40 to more than 70. It is favorable in all age group. So tamoxifen was established in a dose of 20 mg, which was a selective estrogen receptor modulator. Now, what can be done? Improvement beyond tamoxifen. So tamoxifen was replaced by AI. Studies were done. Then what was the optimal duration of tamoxifen or any endocrine therapy? Third, if we add ovarian function on with tamoxifen, does it improve the DFS and OS? And again, in adjuvant therapy, can we add CDK inhibitors? So next came the AIs. AI trial like ATTAC trial and meta-analysis show that yes, AI works better than tamoxifen, and even the duration more than, if we extend the duration from 5 to 2 years, the effect on the DFS and OS was better. But then why? Why not all patients can be given AI, and why tamoxifen is preferred between pre and post menopause? So initially what we discussed, the mechanism, we learned that tamoxifen acts on the breast tissue, the ovarian, the uterine tissue, the bones. So it has a negative effect versus a positive effect on the uterus, leading to tamoxifen having a uterine cancer, though the risk is very less, that is 0.5 to 0.4%, and thrombosis. These were the main side effects. And that should be looked upon when we are giving the patient a long-term treatment. Otherwise, the other side effect leading to hormonal suppression, which are both in tamoxifen and AI, will be hot flash, vaginal dryness, myalgia, arthralgia. And myalgia, that will be the more common in the AIs. So AI, we usually use in a post-menopausal patient. What the study showed that if we use AI in a premenopausal patient, it lead to a PCOD virilization. So it is preferred if we are giving AI with ovarian function suppression in the premenopausal patients. And what were the side effect? The cumbersome and the initial side effect that the patient quality of life deteriorate is the vaginal dryness and the arthralgia. That is something that the patient is most irritated about. Otherwise, other that is important is the bone loss or the fracture. So these two should be kept in mind when we are started the patient on AI. Now, so let's discuss further. What else could be done? So first we started with the tamoxifen and the adjuvant treatment. The 5-year number was a random number, but it was more of a common sense that yes, if it was started with 2 years, then it progressed to 5 years, and 5 years was a cutoff age that okay, 5 years we'll give, and it was preventing it was preventing the recurrence and was a favorable and easy to tolerate drug. Then we did study with AI replacement, and it also showed that AI was better than tamoxifen. Then it was planned that to give 5 years tamoxifen, then continue for another 5 years with tamoxifen only to extended endocrine treatment. It was supported by the ATOM and the Atlas style. Another approach was to give it 5 years for tamoxifen and continue for 2 to 3 years with AI. Then that was the ME17 study, again a positive study. Then the third was either to give it tamoxifen, then switch over to 5 years of AI. So other studies also, like the ideal study, they also supported, and it was a positive in terms of DFS. So this is the initial that we had talked about. The Atlas and Atom are both 5 + 5 years of tamoxifen study, which showed a better DFS and OS. This is the summary of all the trial. In the extended duration, we can see that it was initially tamoxifen and then switching over to AI. Now, a few points for practice to discuss here will be, which patient will you prefer, tamoxifen or letrozole? So basically, in point of practice will be adjuvant endocrine therapy has to be given in all hormonal positive patients. In premenopausal, we generally give tamoxifen, that is for 5 years. And in postmenopausal patient, letrozole and anastrozole can be given. Another point of contention will be the how to decide the postmenopausal status. Because many a times when we give chemotherapy, patient usually goes into amenorrhea. And anytime the patient is perimenopausal, at that point of time, if we have started a patient on tamoxifen, we should keep checking the estradiol levels at least every 6 monthly or so to check if the patient is postmenopausal status or premenopausal status, because after chemo, some patient will regain and some will not. But if there is menopause, it is not the only, if there is no menorrhea, it's not the indication of postmenopausal. NCCN has a very definitive diagnosis definition for menopause, that is age 60, more than 60. The removal of the breast and ovary and hysterectomy is already done, and patient is amenorrheic for more than 1 year. So these definitions need to understand. So any patient will premenopausal prefer tamoxifen. Now the second question, will you go for 5 years versus 7 years versus 10 years? Firstly, we'll see what is the benefit. Yes, the DFS benefit is there, the OS benefit there, and it can be in the tune to 5 to 6%. Now, we should also understand that AI is better than tamoxifen. It has proven, but it does have a side effect profile, and it is not a very easily tolerated drug. Now, what was the add-on study on this? Then came the ovarian function suppression. Both the soft and the text trial were a positive study, and they did show a DFS benefit in the tune of 5 to 8% at over the time of 12 years. So, which patient will you prefer to give ovarian function suppression along with the tamoxifen versus the AIs? So usually any patient which are on high risk category, be it by the younger age of the patient, the higher nodal status of patient, or the grade of the tumor. Any patient that are higher risk should be advised ovarian function suppression along with the endocrine therapy. Second question, usually any patient, because it has the quality of the life of the patient deteriorates if we are combining the OFS with the tamoxifen or the letrozole. So we should always check and explain the patient the toxicity associated, because what we are targeting are the young population, and young patients with such any patient, we are just add on side effect profile in a patient who is already free of the disease. So we should be very active to advise also, even to extend also, or supporting the OFS benefit. So in practice, the patient should be clinic counseled also, and adherence should be checked. And anytime patient is having side effect, be it the bone side effects also, should be counseled. Now, the practice point of view, two things we can discuss is, anytime we are starting the patient with AI, that is the bone, it will affect the bone density. So what is required is to advise a 1 gram calcium with vitamin D supplement to such patient. DEXA scan usually first annually and then every 2 years can be done. Not all patients require zoldonate in terms of bone health. Any patient who is osteoporotic can be advised zoldonate in a dose of 4 mg every 6 monthly. And in tamoxifen patients, as we discussed, the two major side effects will be DVT, and the second will be uterine cancers. But usually it is not advisable for ultrasound uterus. But yes, if the patient anytime reports spotting, then it needs an urgent evaluation. Now, what is the newest data in the early breast cancer is the entrance of the CDK inhibitors. CDK inhibitors initially came in a metastatic setting, and it showed very good PFS benefit and OS benefit with ribociclib. Now, these same CDK inhibitors were added in the adjuvant setting with endocrine therapy. Initially, the PALAS, that is the pelvocyclib study, was did not prove to be beneficial, but the Monarch-E and the Natalie trial have shown DFS benefit in patients that were considered high risk. High risk, be it in the node positive in the Monarch-E or node negative but high risk in the Natalie trial. So in basics of pelvocyclib and abemaciclib, so these drugs act on the transition from G1 to S phase. So it is act by the CDK inhibitor, it is acting on G1 to S phase. And we can see that consider that abema in generally is considered more potent drug than the pelvocyclib. That could be the one reason that pelvocyclib, be it in the metastatic setting, has not shown an OS benefit, and in the adjuvant treatment also, it has not shown benefit. Now, what are the indication or what does the guideline say tells us? As per the guideline, any patient of early breast cancers with more than 4 positive lymph nodes or 1 to 3 positive lymph nodes with one of the following features. That is the high grade tumor, the size of the tumor of Ki67, that is more than 20%. Be it adjuvant abemaciclib or adjuvant ribociclib. The data is more stronger and the guidelines preferred is the abemaciclib because it is a stronger and longer data. And we can see as this table, it shows that the abemaciclib is usually considered in the node positive patients only. And if they are higher grade and higher Ki67. But ribo was studied in even the node negative patients, be it genomically high or pathologically high risk as per more than 20%. So the duration of abemaciclib is 2 years, but the duration of ribociclib is 3 years. And the side effect profile of abema more was the GI toxicity, and adjuvant ribo was more QTC prolongation and the neutropenia. So abemaciclib is approved. Now, the clinical, the practice and the controversy we can discuss of the adjuvant CDK inhibitors. Firstly, there is a data in a new trial has come that there is a point of discussion. First, which one to we prefer? And if do we really have to use CDK inhibitors in early breast cancer patient and subject the patient to the side effect of these two drugs, both the financial toxicity also. So, because both of the studies, have shown have a DFS benefit, but it is shown a DFS benefit, but adding 2 years or 3 years of treatment, both the financial toxicity also. And second question is, if we are using the CDK inhibitors in the early setting, early breast cancer, what if the patient relapses or have a recurrence? Then what will be the second line of treatment? And even if we are using the adjuvant endocrine therapy, only just endocrine therapy without any CDK inhibitors, and then the patient relapses, and if we start any CDK inhibitors, is it changing the OS ultimately? So these were the few points. There is a contention. So, but at present, the adjuvant abemaciclib is the approved therapy in high-risk category as per with the adjuvant treatment. Another is the Olympia trial. Olympia trial has established olaparib as the adjuvant treatment for a period of 1 year in patients with germline BRCA mutation positive and hormonal positive. It has a very strong data for long-term strong data for this, and it has both the PFS and the OS benefit in patients, a significant PSF and OS benefit. So FDA has approved the olaparib for the adjuvant treatment in the germline BRCA in HER2 high risk who have received the chemotherapy. So if any patient who is hormonal positive, germline BRCA and high risk category, if it is preferred to use olaparib initially, as with the data for olaparib will be stronger in a germline BRCA positive patient than a CDK inhibitor. So it should be preferred. Now, this was the early breast cancer. Now, let's come to the metastatic hormone positive. So, what all choice we have in the hormone positive metastatic setting? Initially, we should understand the biology and the clinically how it happens. So, most of the hormone positive breast cancer patients have usually present in a year, like in a 20 years, also 15 years, they have a long DFS, but they usually present after 15 to 20 years, either with a bone-only disease, some patient with present with a visceral disease also, and some are de novo metastatic also. So the upfront treatment will decide on basic on two things. Is the patient endocrine sensitive versus endocrine refractory? Is the patient in visceral crisis? versus the patient is in imminent visceral crisis. So these are the basic overview of the management. In the first line, what is preferred are the AI or fulvestrant with CDK4 inhibitors. In the second line, on the basis of precision molecular profile, it can be targeted treatment targeting the PIK3 ESR1. Another will be the oral SERD, then the chemotherapy, and the later lines, TDXD and cetuximab and other germline mutation drugs can be used. So initially, what will be the endocrine sensitive population? They will be mainly the patient who are endocrine naive and come with a de novo, or there has been a long gap between the treatment of the adjuvant endocrine therapy. Another will be the endocrine resistance. So the definition is important that the patient who relapse on the first 2 years of adjuvant endocrine therapy or progress within the 6 months. And these will be the primary resistant cases, and the secondary resistance cases will be those who relapse while on adjuvant treatment after the first 2 years, and or they relapse within 12 months of completing the adjuvant treatment, or they progress more than 6 months. But as such, it is like to be stressed that 6 months, if the patient comes before 5 months or come after 7 months, it's more of a clinical decision. Like one could assess if there is a bone only disease, or it is patient have lung mats, liver mats, visceral mats. So that should be a criteria. So but more on overview, we should understand what is the primary endocrine resistance and versus a secondary or acquired endocrine resistance. Now we'll start with the basic. So we initially saw how the estrogen acts on the estrogen receptor in the cytoplasm and in the nuclear and passes on the nuclear membrane and acts on the DNA. Another mechanism that is taking place is the CDK. CDK combines CDK4/6 combined with the cyclin D and phosphorylation of the RB, and it releasing the E2F and causing and leading to cell proliferation. So we are blocking the estrogen via tamoxifen AI inhibitors or the estrogen receptor modulators versus estrogen receptor destructor, like the SERD, like fulvestrant. Another what we are targeting will be the CDK4 and 6 inhibitors. These are the two drugs that will be used in the primary setting. Then, if the drugs that we are using, be it the CDK plus AI, what we discussed, yes, it is primary endocrine sensitive, the drugs will work. What will be the mechanism of resistance and how it can be tackled? Initially, we have discussed like HER2 receptors have a crosstalk between the HER2 and the estrogen. Another pathway that is the bypass pathway that can happen is the PIK3, AKT, and mTOR pathway. That can be acted upon. Another is the germline, like leading to the PARP and PARP inhibitors can be used. Otherwise, the HDAC inhibitors. So what will be the pathway for endocrine resistance? The important we can see if a ligand independent ER transactivation happens. In this, we need to remember the ESR1 amplification because and mutations that can be happen with the ESR1 gene. Another, there can be, initially we have discussed the co-activators and the co-repressor in the type 1 and type 2 genome. There the amplification and suppression can happen. And there can be ER loss, be it by ER mutation in the ER expression and other methylation pathway. It could be a primary or secondary resistance. Now, let's start. We know that metastatic breast cancer, initially it was the endocrine therapy, but now the latest data is supportive of endocrine therapy with CDK4 inhibitors. The initial Paloma trial was palbociclib, Mona Lisa for ribociclib, and Mona for abemaciclib. All these drugs, we can have a good follow-up data that around of 8 years. And it was the disease, visceral disease was there, like liver and lung mass was there with bone disease also. And it has showed a PFS benefit. The Mona Lisa trial. So in basically, we have a PFS benefit that is doubling, like 15 to approximately 28 months, 16 to 25, and 14 to 30 months. And a very good OS benefit, numerically, it was seen between 51 and 53 with non-significant. And another, it was numerically again 53 to 66. But in ribocyclic arm, it was a it was a significant benefit from 51 months to 63 months. And the majority of the population was in both then a Mona Lisa 2 trial and again in the Mona Lisa trial 7. The premenopausal patient also had a OS benefit with the CDK inhibitors plus endocrine therapy. Now, what were the basic side effects? So as per we all know that it is the standard of treatment is combination of endocrine therapy plus CDK inhibitors. In the clinical practice, what we see most commonly is the neutropenia with palbociclib, with ribociclib both. But though the neutropenia is in the tune of 60%, but febrile neutropenia is just in the range of 2%. Another that is important when the patient is on ribociclib is to follow up the patient for QTC prolongation and LFTs, with derangement or LFTs. In abemaciclib, the GI toxicity is more, that is in the tune of 10%. So as per we know that palbociclib is a well-tolerated drug in comparison to the two. It is less monitoring is required, and so it can be preferred in the patient who are older and less mobile. But the data as such, which OS benefit is showing, is the ribociclib in comparison, is a stronger data in favoring the ribo and abema. So this table help us for the management of the side effects. Usually, if the patient, this is the general principle we follow. If the patient is, we have started any of the drug CDK inhibitors, to do a CBC. Initially we do twice in the first month, then every 2 monthly it can be done. And other ribociclib baseline ECG is required, and also on follow-up it is required. Otherwise, LFT as same as we do with the follow-up CBC. So usually it is manageable. The side effect profile is manageable with CDK inhibitors. Now, another is fulvestrant. Fulvestrant has, it is a SERD. It is an injectable SERD. The initial study that established its role was the Falcon trial. In the Falcon trial, it showed the benefit. The dose will be a 500 mg, day 1, day 14, then day 30, then monthly, then onwards. The side effect profile will be similar to cause menopausal symptom, vaginal dryness, and the mechanism of action is estrogen receptor down regulator. So basically, it does not have a role in adjuvant setting, but it has established role in the metastatic setting. So initially, what we saw that it was combined, the CDK inhibitors were combined with the AIs, but in both in the first line, fulvestrant can also take combination has been done, and it has shown benefit also. And 2 studies as depicted with the Monarch and the Mona Lisa have shown an OS benefit. So basically, the combination with CDK inhibitor can be AI versus an injectable tablet or versus a fulvestrant. Usually, as per the Parsifal trial established, same only. So in clinical setting, if the patient is de novo and not an endocrine sensitive Usually because the conveniences of a tablet is preferred, usually AI is preferred with CDK inhibitor. Otherwise, it can be interchangeable. Now, this is an important for the clinical practice, the visceral crisis. There has been a plethora of different definition of visceral crisis, but what important and what has been defined is the cutoff value. That has been defined by the ABC consensus. Consensus is the lung visceral crisis that is rapidly increasing dyspnea and rest and not relieved by drainage of pleural effusion. And the cutoff for liver visceral crisis is bilirubin more than 1.5 times the upper limit of normal. These two definition has been established, but other like SVCO syndrome or leptomeningeal mats, the cardiac tamponade, pancytopenia due to medullary infiltration, these can also be clinically important in visceral crisis. So usually the general approach is if the patient is in visceral crisis in metastatic hormonal positive, chemotherapy is preferred. But just the presence of mets does not amount to visceral crisis. If there is just lung met, just liver mets, and the function is not deteriorating, or even if you have a pleural patient with pleural effusion who is a dyspneic, but if you drain the effusion and patient is clinically better, then also patient is not amount to visceral crisis. Because we have seen, as per the right study, why chemotherapy is preferred over endocrine therapies? Because chemotherapies action is fast. So usually we have within the 4 to 8 weeks, we have response. That is why in aggressive disease, it is preferred. As per the right choice, it has shown that CDK inhibitors can also be very active because they usually, the result can be seen within 8 weeks. So they in aggressive patient or with visceral mats also, CDK inhibitor with combination of endocrine therapy can be preferred. But one important is that usually this study included patient with a bilirubin of less than 1.5. So it is more for a patient on for rapid disease progression or patient or impending visceral crisis, a combination can be used. Another trial, that is a Sonia trial. Sonia trial is from the group of common sense oncology, it can be said that as we have established that yes, the AI is in a metastatic breast cancer works well. Do we really need to add a CDK inhibitors? And is it really helping for in the OS different was, although data was there, but in practical setting, do all patients need a CDK inhibitors with the AI? So what this study did was that it enrolled patients with both pre-post menopausal and which were not in visceral crisis and metastatic breast cancer with and categorized with PFS1 and PFS2. The primary objectives were PFS versus PFS2. Initially, a group of patients was started on AI with CDK inhibitors. On first progression, shifted to fulvestrant. Then on second progression, as per the treatment of choice. And the other was the only patient were given AI, and on progression, they were added a CDK inhibitor. As you see the graph, usually it is lying one upon the other. So it's showed that there is no difference in the PFS2 and the OS between the first and the second line. So in practical setting, if we are giving the patient AI and on progression, if we are adding a CDK4/6 inhibitor, we are not affecting the OS and still the patient OS is achieved by both the treatment approaches. What it does, it saves the treatment cost because initially if we are giving in the first line, then the duration of CDK inhibitors is around 2 years, approximately 24 months. But when we are using it in the AI first and then on progression, we are adding the CDK inhibitors, then duration is around 8 to 9 months. And again, this is decreasing the financial toxicity, the cost to be bare, and also the tolerability and the side effect profile. So this is one approach that can be used practically for early versus delayed CDK inhibitors. Now, we discussed the endocrine sensitivity. Now let's come upon the endocrine resistant cases. So usually resistant to anti-estrogen can be via any of the pathway, and resistant to both, be it CDK inhibitors or estrogen pathway. So these could be any mechanism of resistance could be there. So what should be done? Any patient who has a progression, patient should undergo an NGS. NGS can be done on a liquid sample or tissue sample. On basis of molecular profile, the next line of treatment can be decided. This is an important pathway. This is the PIK3, AKT, and mTOR. And in the resistant cases, in endocrine resistant cases, approximately 40 to 50% our patient have working on via this pathway only. And both important to say is this mutation can be present in primary tissue also, and but the treatment is usually decided on the on progression. So these are the studies we all know. The Solar World trial, that is the alpelisib plus fulvestrant base. The Captoro trial, that is capivasertib plus fulvestrant base, and the newer, which is the invasulib plus palbociclib plus fulvestrant. These studies have shown a positive benefit. So what to be done is to test the ESR1 in the PIK3 mutation. That can be tested on blood sample, the ctDNA, and the tissue sample. Another important and the role of ctDNA in hormonal positive patient. So it can be used in the metastatic setting to diagnose any mutation. ctDNA role also is there in patient of adjuvant treatment to decide the optimal and duration of treatment and to detect the early relapse cases. So ctDNA is growing studies, they're like CHIRP study, but yes, till the role in prognostication and treatment change of ctDNA is coming in picture nowadays. So this is the Bolero trial. This was the trial and this was the drug that before CDK inhibitors we used to use. It is a combination of exemestane with the everolimus versus, and it has shown a good PFS benefit in the tune of around 6 months. But it did not have a very strong OS benefit as such. Now let's talk about the basic of the PIK3. So basically PIK3 alpha isoform is the one that being targeted. So alpelisib has demonstrated the anti-tumor activity in the PIK3 alterations. So this was the Solar 1 study. It was the patient was the advanced breast cancer and without any chemotherapy, prior chemotherapy, because the study, in this study, only 6% of the patient had prior CDK4 inhibitors. And mostly patients were unselected but stratified with the PIK3 mutation. The combination arm was the fulvestrant. We can see the PFS benefit with a significant PFS benefit with hazard ratio of 0.6 in patient with mutant. And in non-mutant patient, hazard ratio was 0.8. So basically it is active in a PIK3 mutant patient. A combination of alpelisib with fulvestrant can be used. And another benefit will be it prolongs the time to next chemotherapy. Now, another study was the Believe study that has 3 cohorts. And initially the cohort 1, that is the alpelisib plus fulvestrant, have shown a current analysis, and the study actually helped and establish the Solar 1 study. Another that is important, the side effect profile. What is the hyperglycemia is very important side effect profile in these patients. So before starting and during treatment also, HbA1c monitoring is important, and if required, treatment according to the glycemic level is required in such patients. Another mechanism that is the Again, we have this is the RAS-REF MAPK pathway, the PIK3 AKT pathway. So PIK3 we have discussed. Now it is the AKT inhibitors, the capivasertib and the iptasertib. So basically, capivasertib, the CAPItello trial. The CAPItello trial, it showed a PFS benefit that was clinically significant in the unselected population and the with mutant, and targeting the only the AKT mutant patients. Again, a PFS benefit with a favorable hazard ratio of 0.5, and it established and approved the drug. Another, these are the NGS based and patient we have a targeted treatment. Now, another practical approach would be, what if we change the partner of the CDK? Either we change, if the patient is on palbociclib, we switch to ribociclib, or a patient is on palbociclib and we are switching to abemaciclib. Usually, so the ribociclib showed a benefit, clinically significant benefit in terms of PFS around 3-4 months. And Monarch study also showed a PFS with a hazard ratio of 0.73. Although the palbociclib was not statistically significant. So this could be one approach where we can change the CDK inhibitor with an alternate approach, though it will give us some window of 3 to 4, a few months as such. Now, this is something that we have discussed. Another is the point mutation that can be taken is the estrogen receptor mutation. So ESR mutation is there. So for this, we have a new oral SERD is available as and it has established for such patient. We can use the targeted therapy for such patient. So basically, like we have seen, the PIK3 and AKT mutation usually are present in the primary tissue and more endocrine resistant. But ESR1 mutation are more commonly an acquired mutation, and the frequency we can see it is more commonly present in the after we expose the patient to endocrine therapy and in metastatic breast cancer setting in after treatment is given. So this is the Emerald study that established the oral drug. In this patient, we can see in the ESR1 mutant patient, their PFS benefit again with a hazard ratio of 0.5 and clinically significant. Another with the patient who had more than 12 months prior to CDK benefited more in comparison that with the PFS benefit of 2 versus approximately 8 months. So these are the Emerald type we have discussed. Another down the line were the another chemistrand, jadestrand and imulostrand, other oral SERD are coming in the pipeline. So more or less, what is the biology or how is the usually happens? Like initially patient endocrine sensitivity, we start the patient on endocrine therapy with CDK4 inhibitors, that give us a median PFS of around 24 months. Then we again subject the patient to a second line endocrine therapy, either with a target agent, be it with AKT, PTEN inhibitors with everolimus, or switching of another CDK inhibitors. Again, that gives us around a PFS benefit of 6 months. But usually when we enter a patient, after that is a median time, we have taken around 3 to 3.5 months is usually a patient reach in the endocrine resistant state. So what can be done in a patient who is endocrine refractory or patient is visceral crisis? So in endocrine refractory, again, as per the molecular, we know that the HER2 on the basis of the HER2 low can be used. Another in patient with HER2 0, seziotumab ADC can be used. Otherwise, in patients who are germline BRCA, PARP inhibitors can be used, or if nothing is targetable and not required, then chemotherapy can be used in such patients. So basically, the PARP inhibitor has established its role in patient with hormone positive patient who has progressed with giving us a PFS benefit and with a hazard ratio of 0.5. So NCCN have also given in the guideline of HER2 low also. In HER2 low, we know the Destiny trial, which has established the patient for HER2 low with a payload of 8:1 comparison to, although there is no cross trial, although no comparison of trastuzumab versus sacituzumab. Otherwise, if the patient is HER2 low, the preferred treatment line will be Enhertu. So these are the ADCs that can be used, and again that is supported by the NCCN guideline we can see here. So in basically, if germline mutation positive versus patient if HER2 candidate of HER2 low, or ADC can be used. So this is the treatment algorithm we have discussed in MBCs, metastatic breast cancer, and hormonal positive. Initially, if patient is in visceral crisis, chemo can begin, but mostly 90% of cases go on for endocrine therapy. NGS is important and targeted therapy. These are the 3 targets and drugs that are available with us. And if patient become endocrine resistant, then also we can go with ADCs versus PARP inhibitor versus the good old-fashioned chemotherapy. So, and these are the few newer trials that are going on. So thank you. I hope I did a justice and open to questions now.
Thank you, ma'am, for such an informative presentation. It was really a very good presentation covering all the aspects of hormonal therapy.
Thank you.
Yeah. All the participants are requested to ask the questions in the chat box if you have any queries. So far, ma'am, there are no questions. I would like to request our chairperson, Dr. Srinivasa, sir, if he wants to add on something to the talk.
Not much really, ma'am. Ma'am gave a very elaborate and even the intricate details were dealt with very properly. Like, so the take-home message from here would be like, as ma'am has told, like for early breast cancer, when to give what, whether
Dr. Srinivas, you're not audible.
Hello, sir. Yeah, I guess he's not audible. Ma'am, till then, I have a question.
Yes.
Ma'am, in like, suppose a patient clinically PT3N1 who's completed radiation, everything, was on adjuvant endocrine therapy, premenopausal patient on tamoxifen, but she's having worrisome myalgia and arthralgia, which is affecting the quality of life. So is it advisable to stop it, like almost she's completed 1 year after completion of 1 year?
I think with tamoxifen, arthralgia will not be much of a complaint. I think patient usually tolerate tamoxifen better. You can switch if the patient is post-menopausal, usually then we prescribe AI. Yes, but if patient, at least it is advisable to give 5 years of endocrine therapy. To extend or not to extend is both your decision and the patient decision. If the patient is not able to tolerate the endocrine therapy, then if you are stopping at 5 years also, then it's all right. but usually at least to complete a 5 years is preferable. At times, the
Preferable.
change of brand can be done, which might
Okay.
affect, can be used.
Okay. And also, ma'am, like if the patient is like locally advanced breast cancer, postmenopausal woman on letrozole, but she's a cardiac patient and she's taking antiplatelet therapy for that. So any special measures we need to follow because as these drugs have thromboembolic events associated with it.
That won't be like basically no other measures are required as such. Only a monitoring will be will suffice. Otherwise, you cannot with basically letrozole will not be an issue. Again, in this setting, tamoxifen is something that causes DBT. Letrozole will not have so much of incidence. So usually we advise it to give and to patient to be followed up with both cardiac and medical onco.
And for like metastatic patients, like as you said, who are not in visceral crisis, but like they have proven liver mets, so palbociclib is safe to use
I generally like
until
if
further
has
crisis.
I generally if the patient have effusion also pleural effusion liver and still because that I generally give ribociclib, so it does show a good benefit. Otherwise, if the patient has lymphangitic carcinomatosis anything, so then chemo works. But yes, not visceral crisis, but impending visceral crisis, CDK inhibitors works. Practically also seen, and the trial has proven the same.
Okay. There are no questions so far from the audience.
Aditya, I think sir has joined. Srinivasa.
Okay, ma'am. Yeah, sir, actually, we've lost your voice that time. Like, we could not hear you what you were saying.
I think the mock drill has started in Bareilly. I think they took the power off. Like I'm just
Okay.
right note. Yeah. So that's what we have. It was an elaborate presentation. I should say it was wonderful. Like even we got to revise few things which we already know, but and also few newer things like Madam has touched upon the Emerald trial, LSC strand, which is like and various other therapies which are especially in metastatic breast cancer. The options of LSC strand was discussed and capivasertib. And no, these things when they should be considered. Madam has told the importance of NGS, how to do it, when to do it, when we need to think upon. Like there are many corporates right now. We are doing the in a first line metastatic breast cancer itself. They are going ahead with an NGS, but always at a progression or beyond one the first line only we need to prefer. And regarding trastuzumab deruxtecan also Madam has touched upon the HER2 low, which is making a lot of noise in all the conferences, I should say. Yes. So I think everyone who has attended this conference has got enlightened, like good knowledge regarding the breast cancer, and it will only help us further in managing one of the most commonest cancers which we see in our regular outpatient departments.
Yes, sir.
Thank you, sir. Thank
So,
you.
Yes.
I guess there are no questions. So probably we can close the session. On this closing note, I would like to thank our chairperson, Dr. Srinivasa sir, and our speaker, Dr. Anushree ma'am, for this wonderful session today. Thank you, ma'am. Thank you, sir.
Thank you.
Thank you.
Yeah.